Hello, my name is Amanda Chao, and I'm an MSc Population Health graduate from UCL. I'm currently in Vancouver, BC, Canada, working as a policy analyst with Vancouver Coastal Health. Today, I'm excited to present my findings from my dissertation, which is a systematic review of barriers and facilitators to diagnosis for rare diseases. The co-authors of this review are Drs. Amy Hunter and Jennifer Jones from Genetic Alliance UK, and also Drs. Angus Ramsey and Holly Walton from UCL. So the diagnostic pathway can be really long and complicated for many rare disease patients. It's also commonly referred to as the diagnostic odyssey. An average rare disease patient will consult 5 different doctors, wait 4 years to receive a diagnosis, and receive 3 misdiagnoses before receiving an accurate one. It's important that patients receive a timely and accurate diagnosis, as it allows them to access the appropriate treatment and services. Having delays in diagnosis can negatively affect their health, finances, and work or school, and cause lots of stress. So in order to receive a diagnosis faster, or reach a diagnosis faster, we need to better understand what factors affect the time to diagnosis. So reaching a right diagnosis faster was actually listed as the #1 priority of the 2021 UK Strategy for Rare Diseases. And in line with that goal, the aims of this review were to first examine the barriers and facilitators to diagnosis of rare diseases, and secondly, to explore whether and how these barriers and facilitators might differ across OECD countries. And so to address these aims, a systematic review was conducted with thematic analysis. And initially, 1,430 papers were found, and 27 studies ended up meeting the inclusion criteria and were analyzed. These studies were published between 2012 and 2021 and included quantitative, qualitative, and mixed method studies. The studies examined either rare disease patients, their families, or healthcare providers. So overall, 24 OECD countries were represented across all of the included studies. The graph on the left shows countries that were represented in at least 2 studies. Australia, Germany, UK, and USA were represented the most out of the included studies. The chart on the right shows whose views were represented in the studies. So 75% of the studies examined patient or family views, and 25% represented the healthcare provider perspective. The chart on the left shows the study designs of the included studies. So majority of the included studies were quantitative, 74% were quantitative, and 15% were mixed method studies, while 11% were qualitative studies. And then on the right, we have the included studies sample sizes. So just under half of the included studies had over 100 participants, 26% had less than 50 participants, and the other 26% had between 51 to 99 participants. So what are the main barriers and facilitators? So through thematic analysis, barriers and facilitators were organized into 4 main categories. First was disease factors, or factors relating to disease characteristics, meaning the characteristic symptoms of a disease. Examples include how specific or non-specific symptoms were, or whether symptoms were mild or severe. 2 was patient and family related factors, like sociodemographic factors. 3, healthcare provider related factors, for example, rare disease knowledge or appropriate specialist referral. And 4 were systemic factors, defined as those related to the healthcare system, including things like testing resources and workforce training. Further subthemes were developed and organized into these 4 categories, but in the interest of time, I'd like to focus on the main factors influencing diagnostic time. So one of the major barriers to diagnosis at the disease factor level was having non-specific or mild symptoms. Another major barrier at the patient or family level was being of older age, or the patient being at older age. So for example, older patients felt that clinicians were more focused on treating symptoms rather than finding the root cause. Another major barrier at the systemic level was barriers in accessing appropriate specialist care due to either lack of referrals or lack of trained specialists. Another major barrier at the systemic level was limited availability of diagnostic testing resources, such as the testing laboratories and testing interpreters. On the other hand, major facilitators at the disease level was earlier manifestation or more severe symptoms, so these were dependent on disease characteristics. Another major facilitator at the healthcare provider level was having and receiving an appropriate specialist referral. Another systemic level facilitator was having access to multidisciplinary specialist centers. So that improved the continuity of care and also the communication between the healthcare providers and sometimes also the testing laboratories. And finally, another major facilitator at the systemic level was attending postgraduate continuing education training for rare diseases. So now that we've identified the major influential factors, where do we go from here? Well, perhaps addressing systemic factors has the greatest potential to improve diagnosis. For example, improving education and training for healthcare providers could lead to an increase in the number of trained test interpreters, and therefore increase the capacity for diagnostic testing. More training could also improve clinician knowledge of diagnostic indicators, which could facilitate earlier suspicions of a rare disease diagnosis. And better training could also improve referral rates by increasing clinician understanding of when and where to refer patients to. And more referrals to specialist care and more trained specialists could speed up diagnosis, as that was one of the main facilitators found to diagnosis. So this example shows the potential downstream improvements to diagnosis that could result from addressing systemic factors. These improvements may also be interrelated. For example, increased training will support increased testing capacity and specialist availability, and the creation of specialist centers, which can also improve opportunities for specialist development. Now on to the second aim, which was to compare barriers and facilitators across the OECD countries. Overall, findings did not vary significantly. However, there were some interesting differences when narrowing down the comparison to countries that were represented in at least 6 studies or more, as shown on the table on the right. For the presentation to care and referral subthemes, Australia and UK studies mention delays in presentation to care and delays in referral as barriers to diagnosis. In Australia and the UK, referral from a primary care provider, such as a GP, is generally required to see a non-GP specialist. Interestingly, these were not mentioned as barriers in studies in Germany or the USA, where access to specialists do not always require referral from a GP. For example, you can skip and pay in Germany to access a specialist without referral, and generally the similar things can be done in the US. Now, minority status and socioeconomic status were also only mentioned in studies conducted in USA. Few studies in other countries examined relations between sociodemographic factors and type to diagnosis, which could indicate a knowledge gap and need for further research in this area. Finally, screening and routine examination were mentioned in studies in Germany and the UK. In particular, one study found that more frequent routine examination in Germany during childhood was associated with earlier diagnosis compared to the UK, where there was less frequent routine examination among children. So, in summary, barriers at the disease, patient family, healthcare provider, and systemic levels contribute to delays in diagnosis. Investment across all levels of the healthcare system is crucial for improving rare disease diagnosis. Based on these findings, recommendations for reaching a diagnosis faster include increasing postgraduate training, especially among primary healthcare providers. Second, improving access to specialist care, so patients can see the right specialists faster. And lastly, increasing testing capacity, so more patients can access diagnostic testing and receive timely results. And finally, I'd just like to thank, again, my co-authors, Doctors Holly Walton, Angus Ramsey, Amy Hunter, and Jennifer Jones, for their expert inputs and support throughout this project. And I also want to thank you all for listening. I look forward to any comments or questions that you might have, and please feel free to reach out to me on my email or Twitter handle listed on this slide. I've also included a QR code link to our Prospero protocol for more details on that. Thank you.